In the department, I'm just going to share a historical background because I know that we, in the Department of Social Development, in the past years, we have not been directly involved in rendering services for substance abuse. So we were used to outsourcing the service, and I know that we used to refer a lot to SANCA and other substance abuse organizations. So what I'm going to share, there's no theoretical background, there's no theoretical anything in reference to theory. But everything that I'm going to talk about is basically based on what we do in practice. And I will also share the statistics because from 2014, when we started doing direct services in substance abuse within the Department of Social Development, it's still a learning journey for us because it's new. We continuously, every 3 years, review how we have been intervening, where are the gaps, and where do we need to improve in terms of our services. I don't know if I need to upload my presentation. Okay. Okay, this is the outline of my presentation. I'm gonna just touch on the background information on DSD substance abuse services. I'll give statistical data, and then I'm going to focus on preparation because we in the department don't do treatment. We refer our clients for treatment to either inpatient or outpatient treatment services. Also look at the definition of the importance of preparation and understanding the cycle of recovery, and also the assessment, preparing substance use disorder clients and families for treatment, family rehabilitation, family reunification and support, and also just look at the effective aftercare services, what works and what doesn't work. The purpose of this presentation is to give an outline of preparing substance use disorder clients for successful rehabilitation and to look at effective aftercare services that support the client's route to successful recovery. The key focus of this presentation will be on practical perspective derived from practical learning experiences in substance abuse services within DSD and in data analysis of information that we got from DSD client base as well as NGOs that participated in the survey. Just to give a background, this information is basically a Sedibeng information. Why it is Sedibeng is because in Sedibeng we are the only region that actually implement the direct services in substance abuse in the manner that we are implementing it. The other regions are not yet where we are, and as a result, this model that is being used in Sedibeng, the provincial office is actually looking at making this model a provincial model that we can use because we have proven that it works. Oh, sorry, where did I go? Okay. Okay, as indicated in the department, we used to outsource our services for treatment abuse to NPOs. Prior 2014, the department's main focus on substance abuse was on prevention and awareness, and also including the local drug action committees. Those that were in substance abuse in the regions will know that we used to have what we call the local drug action committees that were later then transferred to municipalities. In 2014, we in the department began a process of introducing internal substance use disorder services, and with the absorption of the new social workers, we also introduced specialized services for SUD. One of the things that we also learned from that is that when we were introducing this service within the department, we used our newly qualified social workers, which actually proved to be a very, very bad approach. But however, we also then decided that we started with this process, therefore we cannot go back, but we can look at how we move forward. So we also just made sure that we intensify our training program. And that is why in the end we entered into an agreement with Wits University to provide our social workers, our new cadre of social workers, to train them in special services for substance use disorder. The specialized service was not only focused on prevention and awareness, but also included intakes, assessment, and referral to rehabilitation later. And at a later stage, we started with the aftercare. On an annual basis, an analysis on data for referrals was conducted, which included tracking clients that completed, those that did not complete. And in 2017, in Sedibeng, we conducted a survey to determine the success of our intervention so that we can identify the gaps in services and thus modified our intervention processes. This was our initial model when we started with the substance abuse. We were doing intake, we were engaging with clients, and then we would do an assessment. But our assessment was not very detailed. We would do just a psychosocial assessment to just determine the family background of the clients that we were referring to rehab, or the client that came to us for assistance in terms of access to rehabilitation. And then we then immediately just refer them to rehab. This process took about a period of 2 weeks or less, depending on the social worker's caseload. And then we then monitor and evaluate the process, but our monitoring and evaluation was just basically getting feedback from the rehab center in terms of the progress that the client was making. And then we do our aftercare. Our aftercare also was not very intensive, it was just minimal. We offered aftercare for a period of about 3 months, and then we would terminate. This is our statistics when we did. In 2018, we then said, let's look back and see what has been the impact of our services. If you look at 2014 when we started, the first blue indicate the number of referrals that we had. If you look at the graph, and then it's a little bit high. We sort of referred over about 50, 55 clients, 56 clients to rehab. And then the red represents those that completed. If you look at the graph, those that completed treatment are very few compared to those that did not complete. When I say completed, is that, remember with voluntary rehabilitation, you cannot force people to stay into rehab. They go into rehab, after 3 or 4 days, they decide, I don't want to be here, and rehabs would then have to release that person because that person is there on a voluntary basis. It's not there because of a referral from court. So if they get into a rehab and they don't want to complete the treatment, they feel this is not for me, then they would leave. So when I talk about the people that did not complete, are basically those that would not even complete the 6 weeks or the 3-month treatment program. They would, in the middle of the treatment, decide that they are no longer continuing with this treatment. 2015, the statistics in terms of referrals went up. We, I think, referred about 70, 75 of them. But if you look at the statistics of those that actually completed, it's also still lower compared to those that would then self-discharge in the rehab. 2016, the same thing, the pattern continued, and 2017, the pattern continued. We then conducted a survey to determine what the problem is, and we identified our problem. Once we had identified our problem, we then modified our processes. In terms of our processes, we started including an assessment. Now, I will go into the assessment as to what is it that we look at in terms of assessment. This assessment became more intense, and the process was no longer a period of 2 weeks. It would take about a month to a month and a half before we could even actually start referring clients. And let me say, this did not go well with our politicians, by the way, because remember, they are number people. Those that work in the organizations will know that the department just wants you to report on numbers. We're not about impact. However, this service of substance abuse within the department is one of the programs that is not number-based. It's not even part of our annual performance plan. It's part of our operational plan, which is why when we render the service, we can actually focus on quality as opposed to the quantity. And then after the assessment, our assessment focused mainly on it was more client-centered. We would then assess a client in terms of readiness for rehabilitation, which is something that we didn't do. It was a matter of a mother would come into the office and say, my child is abusing substance and I'd like my child to go to rehab. And then we'd then do an investigation and would then ask the child, do you want to go? And when I say a child, I'm talking about 20-something-year-olds because they still are children to their parents. And then as soon as they say, no, it's okay, my family wants me to go to rehab, we would then refer. But with this process, we started saying, now we need to look at the client themselves as to whether they really want to go to rehab. And are they ready? And what is the reason behind? What is motivating them to want that change? And then we then do an investigation in terms of what are the other factors, the trigger factors of this person. In the first place, why did they even start using substances? Are there anything in the community, in the environment where they live that actually make them to want to use substances? And then we then do a psychosocial assessment and diagnose whether, remember psychosocial, we talk about DSM-5, whether they are, this addiction is medium or severe or whatever. Then we do that to determine the level of addiction so that we can determine whether this person is a candidate for inpatient or outpatient. And in terms of outpatient or inpatient, it's not about the level of addiction, it's also about the support structure that they have. Will this person be able to attend outpatient successfully or not, looking at the environment and the support that they have, and also looking at the access. And then we then go into a process where we call preparation before we can even refer. With our preparation, and throughout the process, we also include the families. It's not just about the client. We will do an individual assessment to the client, but we'll also do an assessment of do what we call a family assessment to determine what role does the family play in this addiction. Like, for example, Marike talked about the codependent. Who is the codependent within the family? Who is the support structure within the family that can actually assist this client when they come back from rehab? And then once we have referred, our services don't stop there. We continue with our interventions with the family to make sure that when the client comes back from rehab, the environment is conducive for them to maintain sobriety. So most of the clients that we have would be coming from families where there's issues with dysfunction, what we refer in social work, dysfunctional families. So we'd look at, identify what the problem is, and while the client is at rehab, would then address those problems. We would then refer them to organizations like FAMSA. If there's an issue of domestic violence, we then work with the family to address those issues that would actually interfere or become an obstacle for maintenance of sobriety. And then while they are in rehab, we do monitoring. We also, one of the regions that also participate in family reunification services. While the client is at rehab, we start preparing, because remember, there are clients, before they even go to rehab, they have actually ruined all the relationships within the family. So it is important for you to do a family reunification and make sure that when the client comes back, all the issues that the family had, they are resolved, and the family will be ready to welcome this person back into the family. We also then render aftercare. Our aftercare service is for a period of a year. I'm going to go into the aftercare. We used to render aftercare for 3 months, but we have now extended to a year, and it's a very comprehensive and holistic aftercare program, and then we would then terminate. And then with this process, this is what the statistics has given us. If you look at the number of referrals from 2018, when we started introducing that process, we referred over 100 clients. And if you look at the stats in 2018, the number of those that completed training started going up. And then we had fewer people that would discharge before they completed the rehab. In 2019, it still continued. The number of people that completed treatment became higher, and those that did not complete became less. 2020, we were affected by COVID. Those that know why that number of people who did not complete is that our focus after level 5 lockdown, we then were requested to assist the homeless. Now, that came with a compromise on our services. So as a result, we were referring people that came from the state for rehab. And in terms of our preparation of our processes, we were compromised in terms of providing that service. So that's why the number of people that did not complete is actually higher. Okay, I think I have gone into that in terms of the statistics. And in 2020, as I've indicated, it was due to COVID-19 and providing services to the homeless. We were not able to do quality preparation for our clients that we were referring to for rehab. The importance of preparing people for rehab. First of all, it also helps in terms of managing expectations. Most of the clients that we refer to rehab, they expect a 5-star treatment at a rehabilitation center. I don't know, those that are in rehab centers will know. 2 days after we've referred, a social worker will get a call. I thought I'm going to get bacon and eggs here, and I'm not getting that. Whatever the expectations that are there, they don't find, and they find the environment is very difficult for them to cope because they were not informed as to what to expect. It also helps in terms of psychological and emotional preparedness for the new environment. Remember our clients that we are getting, particularly because we're dealing with mostly our Nyaupe addicts. Those are the ones that we are referring most to rehabs. When they go there, they are so used to an unstructured environment. They go into rehab, there are so many rules and regulations, things that they can or cannot do, and they find it difficult to actually cope and adjust. So when we prepare them, we give them information about the facility that they are going to so that they can go and prepare themselves mentally and be ready for what they will be exposed to. It helps to help clients have a clear understanding of why they are going to rehabilitation. They also understand their responsibility to their journey to recovery. So, because sometimes they think it's somebody else who must help them to recover, whereas they need to understand that it is their responsibility. And in our preparations, we also include the family, because often you find families think, no, social workers must just take this child to rehabilitation. I don't want this child. And sometimes even they feel that even the 6 weeks or the 3 weeks period is not long enough. They would like this child to stay as long as they can, because this child has been such a problem. He sold all the pots, he sold all the things that they have in the house. So it is very important to make sure that the family knows that even though we are referring the client, a family member, to rehabilitation, they still have a responsibility to play in terms of assisting this person so that they can maintain sobriety. I also provide information about the facility. Facilities that we refer to differ in terms of roles and how they manage and discipline and all of that. So when we know which rehab we are referring a client, we then give them information about the rehabilitation that they're going to, so that when they get there, nothing is a surprise to them. It also helps them in terms of building resilience. And we also attend to other obstacles in terms of what is it that can interfere with them completing treatment. For example, most of our clients, as we do assessment, we also do a medical assessment. We check if there are any co-occurring disorders or co-occurring conditions. For example, most of the people that go to rehab either have HIV or they have other mental illnesses. So we check if there is any pre-existing, and if there is any pre-existing condition, we then make sure that before they go to treatment, they go with their medication, medical supply for that period of time. If they're going to be for 6 weeks, we make sure that when they get admitted, they have their 6-week supply of medication before they come back. Because in the past, they would go, and then instead of focusing on their treatment, they are worried about their ARVs, they are worried about their medication for bipolars and all of that. We are very fortunate that we have a good partnership with the Department of Health, particularly the mental health in Sedibeng, where they assist us in terms of providing us with that medication. When we do an assessment and find that there is no clear indication of whether there is a pre-existing or mental disorder, because sometimes you find the family doesn't even know that this person has a mental disorder, or there is a drug-induced mental disorder. We would then refer the client to the hospital for a 14-day observation. And Sedibeng Hospital and Kopano Hospital always assist us in terms of admitting clients so that they can give them an observation of 14 days. So when we get the report that actually gives us a clear that there is no mental disorder, or there is, but then they provide medication before we can refer for rehabilitation. That has actually helped. We also, in making sure that we attend to anything that can serve as an obstacle. If there are children involved, we will then ensure that we place children in the place of safety. If there's nobody in the family that can actually assist in terms of taking care of the children. If there are family members that can assist in terms of taking care of the children, then we would then request the family members to take care of the children while the person is attending treatment. Okay, and I think first of all, I'm not going to go into this because this is important for us when we prepare clients for rehabilitation to understand the stages of addiction. And this is the process that we also, the information that we provide to the families in terms of them understanding, because families need to understand that this is a disease, this is a brain disease, and that it's a chronic condition that we cannot say a person has fully recovered. And in the process, we just give them this information about the process of addiction. I'm not going to go into that. I will just skip this slide. And then also, I think Mariki spoke, is it Mariki or Tembi? Tembi spoke about the cycle of the stages of change. In our assessment, we also look at where the client is when they approach the department for assistance. Most of our clients are basically at pre-contemplation, where they, when they are at this stage, they don't really, they don't really admit that they have a problem. It's the family that says they have a problem. So when we get this kind of referrals from families that say, we have a family member that is using substances, and we find that they are not yet at that stage where they admit that they have a problem, we then do not focus on the client, we focus on the family, so that we can help them understand that this person is not at a stage where we can refer them to rehab, but that this person needs to get to a stage where they admit that they do have a problem and they need to change. Because if they go to rehab and it's not them that sees that they have a problem, they're doing it for them. And therefore the chances of them going there, not completing or completing and coming back and relapsing are very high. So at pre-contemplation stage, our focus is mainly on the family and making them understand that at this stage we cannot refer the client. Then you have a contemplation where a client is already realizing that they do have a problem and they need help. But at this stage, they have not really gotten to the stage where they want to, but they acknowledge that they have a problem. And then they start preparing themselves for change. So when they do come to us, we consider it. I know that our cycle compared to the rehab cycle is not the same, because the rehab is on treatment, we are more where the client is not yet at preparation, at treatment. When we prepare them, we also, while we are working with them in that process of 6 weeks before we can refer them for rehabilitation, give them certain things that they need to do. And that would actually guide us as to whether this person has the level of motivation that is required for them to change their lives. I'm not going to touch on the maintenance because that is basically after the treatment. I've spoken about the pre-contemplation, and as Tembi has indicated, and as I have already indicated, that the people don't consider their problem, their behavior a problem, and because it has not yet had a negative consequence to their behavior. So most of the time it's the parents or the families that would report. Our focus here is mainly on the family and providing them with support to cope with the behavior and the consequences of the family member. On contemplation, they already acknowledge that they have a problem, and this is where we use motivational interviewing. Use motivational counseling for clients so that they can be ready for rehabilitation. Then we do get to preparation, where we start preparing them for rehabilitation. We assess their level of motivation. What is it that makes them want to change? How are they going to make sure that when after treatment they will remain sober? We also look at the support system for them when they come back from treatment, and we provide detailed information about treatment. And then we do assessment. I'm first going to define what is assessment. Assessment is a process in which information is gathered in a systematic way using prescribed method and skills, and then put together for purpose of analyzing and gaining better understanding of the problem at hand. Why do we assess? The assessment is conducted to identify the client's problem, the level of addiction, the resources that the client has, the stage of change, the triggers for SUD, interpersonal strength, and developmental areas in order to develop an appropriate treatment program that addresses the client's needs. We need to know that in substance abuse, there's not one glove fits all. So each and every person has their own circumstances, and you need to deal with the client with a unique problem. And then these are the key areas of our assessment. We look at the nature of the problem, the developmental needs and stresses associated with life transition, the coping capabilities of the client and significant others, the strength, the skills, the limitations, deficiencies, personality assets, relevant systems involved in the client's problem, resources available that include barriers, and then the client's motivation to resolve the problem. This is what we look at when we do assessment. And we use a systematic approach basically because it's not client-based, because we know there are factors that actually influence people to use substances or be addicted to substances. That's why we use the system, because we found it to be very holistic in approach. We look at the person, the environment, which is the family, and the community as a whole, and including the friends and the people that the person interacts with. And then this is what we use. We do in the when we do assessment. We look at what is it that brings the client to the offices today, and what makes the client, who makes the client system. And then we also look at the safety of the client, determine if safety is an issue for the client, because most of the time we find that we do get referrals from parents that are actually being abused by the child or the family member who wants money to maintain or support their behavior, and then we immediately provide resources, support, and assistance if safety is an issue. For example, if there's an issue of gender-based violence or domestic violence, then we would then attend to it and make sure that we refer that person for safety. And then we look at survival needs. Are the basic needs met for the client system? What are the other issues that needs to be addressed? For example, we look at what else is there that actually is affecting the client. Then we look at the support or the strength, and then we look at the short-term or crisis work. Is there anything that we need to do that requires immediate intervention? For example, if this person is abusing substances, is a parent, is the substance also affecting how they treat their families, how they treat their children, and so on? Is there any element of child abuse or spousal abuse or so on? Okay. And then our assessment, we make sure that it is very holistic. Then we look at all those areas, vocational services. Most of our clients don't have even matric, so we would then look at what is their skill. When they come from rehab, they can't just be at home. We need to look at what else they will form part of their aftercare. Mental health, are there any mental health issues? Medical, as I've already indicated. Let me just skip that one because I've already spoken about it. And this is what we do when we prepare them for rehabilitation. We look at all these areas, individual or psychological preparation, educational support. If we refer children that are still in school, we have a partnership with Department of Education where we want children that are in rehab to actually continue with their learning. So when they go to rehab, they will take their school material with, and then we'll make sure that when they come back, there is extra support that they will get so that they are not left behind. They are able to catch up with their classmates. We also look at employment. Most of those that are employed, we know that it has implications to HR. We will then, on behalf of the client, be negotiating with the HR to give them time off. And we are very fortunate that when we work with HR through our department, we have been successful so that they can give this person a period of 6 weeks that they will be able to go to rehab, and they consider it as leave. What is it? Sick leave. And then we do aftercare before the client is referred to rehab. We also look at when they come back, what would be our aftercare plan, which will then be reviewed in partnership with the rehabilitation center. And then we also do family intervention services. And why do we do intervention is to make sure that we keep families together. We provide support mechanism to families in order to improve their functioning. We improve the well-being of families. We reunify the family and family members and help the family cope with challenges that may arise and understand the addiction and recovery process of the family member. We motivate the family to support the family member when they come back from treatment. We help the family create a conducive environment for the recovery of the family member. And this is our process that we do when we do family intervention. We do family assessment. We develop a specific family intervention plan, and then we implement the implementation of the plan and continuous monitoring of the plan, because each and every family member has a role and responsibility that they have to play in terms of supporting the recovery. And then we evaluate, and then we terminate once we have succeeded in what we want to achieve. And then this is our aftercare. I'm not going to go into our aftercare. We know that aftercare is very important for the recovery of a person. We have seen over the years that people that don't receive aftercare are at risk of relapsing. So it's very important and critical that all the people that complete treatment, whether it's inpatient or outpatient, also have aftercare services. I'm not going to go into the why aftercare. I've already mentioned, and the purpose also, I will not go into it. And then these are the principles of aftercare. As we say, not love fits all. Aftercare services and programs must be designed for the specific needs of the individuals and their families. Aftercare must be holistic, practical, and accessible. One of the things that we have identified also in the department is that we also started with the funding of what we call schools of excellence. They are basically just established for aftercare programs for people that complete treatment. It's more skills or vocational skills training program. And once they've acquired that, then there's job placement, or they are given a starter pack to start their own businesses. However, because these schools of excellence are centrally based, like for example in Sedibeng, it is based in Everton. Now, most of our clients, if you look at Sedibeng, is very fast. So most of our clients coming from the Sharpeville and Bophelong are not able to access those services. So therefore, it becomes fruitless for us to have only a few that will be able to reach those programs. So therefore, we are saying that aftercare must be accessible. It shouldn't be something that clients must struggle to get to access. Another thing is that we also picked up that because of our waking hours, we work Monday to Friday, and most of the clients that are completing treatment, either they are at school during the week or whether they are at work, and therefore the only time that they can be able to access aftercare is either after hours or on weekends. So we have made provision to make sure that people that are doing aftercare also during the week, they have a day off, because then they'll be doing their aftercare program on a Saturday. Aftercare program must be developed with the client and not for the client. The services must take all aspects of the client that could trigger relapse. Aftercare should not be less than a year after completion of treatment. Formal aftercare services should be followed by non-formal. What I mean by non-formal is that when we do aftercare formally, the support groups and all of those programs that we are doing, we're doing them for the year. But after a year, we do non-formal, where we just do random checks. We follow up with the family, with the client, maybe once a quarter, and so on, just to check to make sure that the client has been able to maintain sobriety. Now, if you look at that aftercare it's a zigzag, there's nothing. They just work in relation to one another. We do have support groups, we do individual support or counseling, and then we also do random testing, and we also look at employment opportunities, we look at skills development, and we look at management of relapse, managing relapse signs and symptoms, so that we can be able to attend to them before the client can relapse. Now, this is what we got from the service users as we did follow up, those that have completed training, treatment, and they are in aftercare. Service providers must refrain from deciding what is good for us and what is not. We know our lives better. We know exactly what we need. Support groups alone will not help us stay away from drugs. We need other tangible solutions. This is what the clients are saying. Government must provide skills training for us, as most of us did not complete matric. Going back to school at this age, after so long, is not a practical solution for my problem. I'm not happy that social workers arranged for the care of my. I'm happy that social workers arranged for the care of my children while I was at rehab. She updated me weekly through calls about my children. I was able to focus on my treatment. The first time I went to rehab, this is a relapse client, I was not ready. My social worker did not give up on motivating me, even after I relapsed. I was ready the second time around, and I was committed. This is a client that has been clean for about 3 years that we followed up on. The fact that the department referred me for skills training and helped me find my job is what helped me to stay clean. I've been clean for 6 years now, and I'm still working as a security officer. This is the client that we were able to take for vocational skills training, and then we partnered with some of the companies to actually look at job placement, and has been employed as a security officer for the past 6 years. So he has been able to maintain a sober life because of the support that he got, which proves that as much as we are doing support groups and counseling, but it needs to become coupled with other services that can actually help them stay sober. In conclusion, okay, can I just finish this? Okay. Right. Your 2 minutes. Oh. Referring clients to rehab when they are not ready for change is not a good thing. Although motivation is a determining factor for treatment, it is as much a client's responsibility as a social worker's responsibility to motivate. It should be noted that motivation is a key to change, is multidimensional, dynamic, and it can fluctuate. It is also influenced by social interactions. It can be modified, and it can be influenced by the social worker or the counselor style. The counselor can enhance motivation. Thank you.